Alrighty, so we see some people are already in the room. Welcome. Um, just going to take a second to introduce everyone and make sure we have all of our everything in a row here. So thanks so much for being here for our very first webinar, and this will focus on understanding psychedelic and ketamine-assisted therapy specifically. It's a very trauma-informed conversation as well. So my name's Alex, and I work closely with the Port Credit Therapy Center on the marketing front and communication side, and I'm also currently training as a psychotherapist. A little bit of housekeeping as well before we get started. You'll see that this webinar is being recorded, and also a replay will be shared with everyone who registered. We'll be moving through a discussion led by Dawn, followed by a time for some Q&A at the end. And of course, if those questions come up for you along the way, you're welcome to drop them into the Q&A section of this webinar, and we'll return to them later towards the end of the webinar. And also for those who feel comfortable, we gently invite you to keep your cameras on, as it helps create a sense of connection and shared presence in this space. Of course, you're always welcome to do what feels right for you. A little bit about the Port Credit Therapy Center as well is that it's a integrated mental health clinic based in Mississauga. It offers psychotherapy, ketamine-assisted therapy, and overall collaborative care with a focus on trauma-informed and relationship-centered support. So to introduce our main speaker, I'd like to introduce Dawn Binkowski, a registered psychotherapist and clinical director of Port Credit Therapy Center. She works with adults and couples with a focus on trauma-informed and psychedelic-assisted care, and brings over 2 decades of experience in private practice. Dawn came into psychotherapy after many years as working as a court reporter in civil litigation, where she witnessed firsthand the impact of stress and trauma, and later completed her 4-year training at the Gestalt Institute of Toronto, building on her studies in psychology and women's studies at the University of Toronto. Her approach is supportive, compassionate, warm, and honest, and she works collaboratively with clients to help them understand patterns that might be holding them back while supporting new, meaningful ways forward. And we're very grateful to have her guiding us in this conversation today. I'd also like to introduce Harpreet Lakhan. Harpreet is a registered nurse and operations manager at Port Credit Therapy Center, specializing in ketamine and psychedelic-assisted therapy. She brings a strong background in community care, supportive housing, and work with vulnerable populations, as well as an extensive experience in clinical supervision and multidisciplinary collaboration. Harpreet will be joining us more towards the end of the discussion during the Q&A portion to help us speak to clinical, operational, and collaborative care aspects of this work. So with that, I'll pass it over to Dawn as she guides us through today's conversation.
Hi, I've just got a few messages that camera sharing isn't enabled for everybody, so I don't know if you can do anything on your end about that. But, okay, hello, hi, thank you for joining us. There is a lot of curiosity around psychedelics these days, and there also is a lot of mixed messaging that is still out there. And I just need to state that today's webinar is for educational purposes only. This is not medical advice in any way, nor any persuasion. Psychedelic and ketamine-assisted therapy isn't for everybody, but it is a really wonderful treatment modality for some people. When looking at psychedelic-assisted therapy, then it is really important that we are looking at safety, ethics, and thoughtful care at all times, so that we can help the clients process trauma that's there and provide a safe environment which facilitates the whole process. And I also want to point out that for centuries, Indigenous cultures have been using psychotropic substances in community, and it has helped process whatever it is that the community was going through. And there is a much lower incidence of trauma, PTSD, trauma, depression, anxiety in Indigenous cultures that haven't been grossly impacted by colonization. So to understand, well, what we've realized is that with trauma, as a result of trauma research, that trauma isn't what the original definition was of PTSD, and that it was when it was attached to an event that someone went through. We now have a better understanding about what's called complex PTSD, and also just about trauma in general. That trauma is something that overwhelms our nervous system, and it is something that makes us constrict and contract away from our authentic selves. And it makes our system function less efficiently. And we also are aware that there is all different types of trauma that comes up. It can occur, as I'm seeing on the slide here, before memory, language, or conscious awareness, precognition trauma, in utero trauma, birth trauma, intergenerational trauma, and ancestral trauma. And these things are stored in our cells, in our body, as a result of adaptations that were made for survival earlier on. Just to give an example of this, in July 2014, there was a research study that was done by Brian Diaz and Carrie Ressler on epigenetics, and they used mice, and they gave mice a shock on their feet when a particular odor was released. And what they found was that the mice, this was just for male mice, and their offspring and further generations avoided the odor, even though they weren't giving it a shock. And so that is the way that it was coming through the sperm, that it had imprinted in the survival mechanism that was something that needed to be avoided. And there's been other studies that have supported this, especially coming down through the female line. Our grandmothers, what they experienced, we realized that that cortisol and the stress hormones go through the placenta to the fetus. So if our mothers were particularly stressed, or our grandmothers were particularly stressed when they were pregnant, that would have gone through to the fetus before the fetus has a chance to be able to neutralize the stress hormones that come out. And so there is an adaptation of the cell biology that is all part of our survival mechanism that can happen. One way of looking at it is trauma isn't defined only by the event, it's defined by how our nervous system adapts to the event and to the overwhelm from a protection point of view. Just looking here, and while it helps to know about our trauma, but obviously there's trauma that we have that we're unaware of, and it's really hard to work on something that you're unaware of in talk therapy. Somatics can help with that in this release, but sometimes that isn't enough either. So most therapists, there's sort of a general consensus that probably about 10 to 15% of our clients that we see don't reach the level of healing that they want in engaging in talk therapy or pharmacological support alone. And that typically we're now finding is because there's deeper trauma, and it either is because it's precognition, we're unaware of it, ancestral, intergenerational trauma. So if trauma lives below language, then healing sometimes we have to go to that as well. We have to look below, underneath what the cognition that our brain has. And this is why talk therapy isn't always enough. Insight doesn't always help to calm the survival brain. And what happens, the way our system is designed, is the survival mechanism part of our brain activates first before our rational brain is even aware that something's going on. So it's, I see a flash of orange, I think it's a tiger, I start running. In a proper functioning system, then at some point when I've got enough safety, then I may actually turn around and take a look and see if that actually was a tiger, or maybe that was George in an orange shirt. And then I'm able to calm my system if I find out that it was George in an orange shirt. What can happen? Well, I put the other piece in there. Then my rational brain wakes up and says, hey, hold on, wait, was that actually a tiger or was that something else? And we're able to reality check as to whether there was actually a threat there or not. What can happen when there's unprocessed trauma is that our system goes into high alert. Oh my gosh, there's that flash of orange. We are in danger. And then the rational brain wakes up and says, oh my gosh, the system is in high alert. There must be danger. And then it looks out into the field and creates a narrative about why these feelings and responses are valid. And this is what happens in trauma. Our brain hasn't fully processed something that had happened before. So our system is in a sense of alert, as though this can happen again at any moment. And that's part of the imprinting. So our body, the amygdala part of our brain that's constantly scanning for danger, gets hypersensitive and is looking for things that might even be remotely similar to a time when we've been hurt. With what is necessary, we're finding in the healing with trauma, is we need to be able to give the body a sense of safety, which gives a sense of control back again. And we complete that loop. Okay, something happened to me earlier, if it's something that we remember, or even something that we're just having a reaction to. We may not understand it, but then we are able to find a way, often through somatics, through doing something, through movement, through getting in touch with our feelings, where we're able to give our brain the message that we aren't actually in danger in order to find safety again. And that often then gives us access to whatever the original, the emotions that were attached to the original event, or recognize that our body is projecting something out onto the present that isn't actually accurate. So the field of trauma research has really opened the door to a lot of these psychedelic therapies and recognizing what's going on. So first I'm going to start and talk about ketamine. Ketamine is the medicine that we use most in our clinic. It was developed in the 1960s originally as an anesthetic, and it was used in the military in the Vietnam War. It was called the buddy drug because it's a dissociative analgesic, and so it helps with pain relief, and it also helps to dissociate. So if someone is in a terrifying situation, it can help them find safety or feel safe in that. And so the buddy drug was that if you were out in the field in Vietnam and your buddy got seriously injured and it was going to be a while before the medics could come and take them out, that they carried, like, it's like an EpiPen, and the buddy would use the ketamine pen on their buddy so that their buddy was able to be more calm and peaceful and not as much in pain until help could finally arrive. It has been used safely in hospitals for decades. It's been an anesthetic. It was one of the safer anesthetics. The other anesthetics would put us into a near-death state, but because this is a dissociative anesthetic, it doesn't have to do that. It actually increases our heart rate a little bit, and it's a little easier to monitor. The World Health Organization lists ketamine on their essential medicines list. And in the early 2000s, it was used, it's still used and was also used then for IV, for pain management through IV infusion. And they started to recognize back in the early 2000s that it also had a rapid antidepressant effect. And it is being used in some hospitals when a patient shows up with acute suicidality. that a shot of ketamine can very quickly help to neutralize the suicidal ideations. Here in Canada, it is legally prescribable within a scope of practice. We need to be properly trained, and certain criteria needs to be met. And that is that typically that someone has tried talk therapy and also has tried pharmacological support and hasn't found the level of healing that they have wanted. While there is a strong case to be made that psychedelics can help with self-exploration and mind expansion and self-introspection, that isn't what's legal here. We need to meet a medical criteria where there needs to be some indication of anxiety, depression, or trauma in order to justify a medical doctor or a nurse practitioner writing a prescription for it. In Canada, we are also allowed to use psilocybin and MDMA, but it isn't legal. In this state, they are still a controlled substance, but through what's called a special access permit application, we are able to apply to Health Canada on behalf of the patient for them to receive that treatment. Right now, psilocybin is approved for end-of-life anxiety and treat major depressive disorder, as well as cluster migraines. There was a Supreme Court challenge for the cluster migraines, and that was on a microdosing level that was successful. MDMA is approval can be granted for PTSD. It is quite a long, involved process that has to be done by a doctor or a nurse practitioner on behalf of the patient to do the special access permit application. And unfortunately, currently there are still significantly more refusals for the SAPs than there are permission granted. And hopefully that is going to change. But there are even reports of people who have been granted MAID, medically assisted induced dying, but were turned down for the end-of-life anxiety psilocybin special access application. So there's still a lot of work that still needs to be done, but there are successful applications that are going through. As I said, it's a case-by-case approval, and this is for these two, they have to meet the criteria of treatment-resistant PTSD or depression. Depression and anxiety can both, they often present with the same conditions. And it's not automatic, and there's no guarantee after doing a special access application that it's going to be successful. But it is wonderful that they are treatment options that we have here, and hopefully they will be expanding as more and more research comes to the attention of the government bodies. I just want to give a little bit of information just about, you know, the efficacy of, in this particular case, MDMA. There was a very significant 3 clinical trials that were conducted by MAPS organization on MDMA in the States. And when you look at what the criteria, what happened, the results, it's quite remarkable. The criteria for being accepted into the study were people with severe PTSD that interfered with their ability to have a productive life. And after the MDMA treatment, 67 to 71% of the people no longer met the PTSD diagnostic criteria after treatment. There has never been a treatment modality with those stats before. Now, there was obviously the placebo groups as well, and both of them had therapy as well, and that's a very important part of this. So 32 to 48% of the placebo plus therapy groups no longer met the criteria, which is wonderful that they were able to feel some support for that. But they went back, 46% met the, sorry, I got confused there. 46% met remission criteria versus from the MDMA versus the 21% placebo, meaning extended for a longer period of time. And there's a follow-up study that showed that the benefits seem to be persisting 12 to 18 months after the study. And when it says no longer meeting the diagnostic criteria, that means the participants fell below the threshold at that time. Not that all the symptoms disappeared, but that they were able to navigate and manage symptoms that came up in a way that didn't throw them right down into dysfunction and not being able to, or being immobilized. With this study, it was all with therapy. And they were structured in supervised clinical settings with preparation and integration. And that is a very, very important part of psychedelic-assisted therapy, ketamine-assisted therapy, is that a way of looking at it is the molecule is the lubricant, but the integration therapy work that happens is what leads to sustainable change. This is not a quick fix. Otherwise, it's a difference between a recreational psychedelic trip and a therapeutic experience. That you do the work afterwards with integration, beforehand in preparation, with assistance through the journey, the medicine journey itself, and integration work afterwards. And there's all different ways that we can engage in integration in order to help anchor the insights that we get from the medicine journeys. In order to lead to sustainable change. And so now why psychedelic-assisted therapy may help. What happens, I was alluding to it earlier, is when we go through trauma, it takes us away from our authentic selves. It narrows our ability to deal with whatever stressor is coming up. And we move more quickly into survival mode, as though whatever the trauma was were happening again. And with these molecules, what happens is we're given more emotional flexibility, a felt sense of safety, and access to somatic and emotional experience. There is an enhanced neuroplasticity that happens, which means that we are better able to get out of the old neural pathways, the ruts, the anxious thought patterns, the distorted thinking, the oh my gosh, there's danger over there. We're much easier to get out of that rut and create a new neural pathway that allows for us to have a healthier response to whatever the catalyst is. The enhanced state of neuroplasticity lasts. We haven't had near enough research studies for all of this yet, but for sure up to 72 hours, particularly with ketamine and psilocybin and MDMA, but there even is some speculation it could go on for a few weeks afterwards. So it is really important to take advantage of the enhanced neuroplasticity, and that's where the integration work really comes in. Fortunately, with these molecules, it doesn't rely on us remembering the trauma. We can have a body experience of something that just emerges, that we're able to work through and process. And I can give an experience when I was in an altered state experience. At one point, I felt an urge to pull I was lying down and I was lying on my back, and I had an urge to pull my knees up. And all of a sudden, I felt terror like I'd never felt before, along with this sense that I couldn't breathe. And I realized that what that was about was birth trauma. The story is my mother was in labor for 56 hours with me. And for sure, there are times over those 56 hours that the umbilical cord would have been compressed. That is not something that I had any memory of. It isn't even something that was in my radar, but that's where my body went when I had this experience. And I was able to work with that in this altered state, using my breath and calming myself. But it was there, and like nothing I'd ever experienced before, to my knowledge. What also happens is that the molecules, in a way, blunt our fear response. And so we're able to process a trauma that we had experienced without fear getting activated and feeling like we're in it again and experiencing it again. It also tends to put what's called our default mode network offline, or it softens it. And that's our ego function. Oh, I shouldn't say that. Oh my gosh, am I too much? These things that we say to ourselves to shut ourselves down. And so that opens up the area for us to explore more within ourselves, because there isn't this governor coming in saying, no, you shouldn't think that, you shouldn't feel that, you shouldn't say that. With MDMA therapy, it is more contactful, where someone will be in their medicine experience, but also coming out to talk and process with whatever is coming up. Whereas with psilocybin therapy, for example, or a high-dose ketamine experience, people have eye shades on and they're given headphones, and there's a curated playlist, and the invitation is to go inward with self as opposed to engaging relationally. With a low dose of ketamine, we do engage. It's a low dose of ketamine in a 2-hour talk therapy session, and it just allows access to a lot more information than what we typically allow up. When combined with trauma-informed therapy, it can support the nervous system regulation. Okay, so you're going through something challenging now. We're going to invite you to engage with your breath and calm, and we'll talk about what is going on, the emotional processing. And then what happens in the integration is meaning making, and that's part of a therapist's job in integration, is to help the client make sense of their journey, not by directing them, but by helping them to capture certain feelings, certain sensations, certain colors, certain things that stood out for them from their journey, that they are then able to look at a certain way that can help give them some understanding of the insight that the medicine was trying to give them. So the medicine creates a window, and it's the therapy that creates lasting change. And it is very important to have the support with preparation, support in the session, and integration afterwards. There's no forcing, there's no pushing past any defenses that might come up. This is all very trauma informed, and everything is an invitation, which is the respect for the protective defenses. Now, this is a wonderful slide. So the image on the left is someone who has been given a placebo, and this is the resting state brain scan of a non-task brain. This is sort of what it's kind of normal, what's happening in connections. And then when you look at the one on the right, that is what happens when someone is on psilocybin. So you can see that there is the ability for all different parts of our brain to connect with each other, it creates a temporary increase in network flexibility. So we're able to process trauma in a different way and have access to things that are in our unconscious, in our subconscious. It's kind of like in a dream state when we have a dream, it doesn't make a lot of cognitive sense, but there's something there that's going on that we're processing. So it's very similar that with the default mode network shut off, so much more is possible with these molecules. And it also, the other thing that it does is it, reduces, what the amygdala does is it reduces the rigidity of threat prediction. This is part of what our survival mechanism does. It is constantly looking for something even remotely similar to a time when we've been hurt. And it throws on the alarm saying, wounding, danger is imminent. And so then we move into our fight, flight, freeze, or fawn response without, as I've said before, our rational brain getting engaged and being able to do a reality check. Am I actually in danger, or am I responding to something that's happened in the past? So, so the trauma has a tendency to create rigid patterns. Again, all attached to our survival mechanism. It's like, you burn your hand on a stove, then you are going to be aware going forward when you are going around a stove, sort of looking at it in a basic way. And the same thing happens. Our body, our physiology responds exactly the same way to the potential threat of emotional pain as it does physical pain. And so, if we were shut down, for example, as a child, and there wasn't support for our emotions, and let's say we were dismissed or cut off, or grow up in an environment where children should be seen and not heard, then what can happen is we can get emotionally triggered when we feel that someone else is doing that to us in our adult life, without recognizing that once we're an adult, we have a lot more tools at our disposal. We can say, hey, no, stop, don't do that, I need to speak, or we never engage with that person again. But typically when the imprinting has happened, we were powerless to do anything about it, which is why it got imprinted. Frequently we were children and we were powerless to change anything. And this is what's underneath, what's called emotional triggers, where we have an escalated reaction to something, whether that is escalated, where there's a lot of energy buildup, or shutdown, we go into freeze mode. I know myself, coming from a people pleaser background, and even though I've done a ton of work on that and I'm able to support myself, there still are times now when I lead with something that I want, I can feel this resistance, like I'm doing something wrong, and that it's going to have a negative impact on somebody. And that's part of the conditioning that I experienced from trauma early on. One of the analogies that I quite like about what can happen with taking a psychedelic substance is, you look at it that you live in a house that's on a hill in the mountains with the snow, and every day you put on your skis, and every day you take the same path down to town, and that becomes the rigid neural pathway. And then you take a psychedelic, and it's like a fresh coat of snow has just landed, and you are able to carve a different path. And this is what the increased neuroplasticity offers us. Now, what I have mentioned before is that, the safety and ethics, and that psychedelics aren't for everyone. Talk therapy works well, as does pharmacological support for many people, especially when working with trauma-informed therapists. With somatics, CBT can be helpful for people that get stuck in negative thought spirals, distorted thinking. It can help for a lot of people. But for those that it doesn't, that's why this is a really important treatment modality. So in order to engage in this ethically, and having safety in mind at all times, screening is essential. And what we go through at our clinic, because we're trauma-informed, take a trauma-informed approach, that first, myself as a clinic director will speak to somebody first just to get a sense of someone who's inquiring about ketamine-assisted therapy or psychedelic-assisted therapy. I'll speak to them briefly first, just to find out if they've done therapy before. And if they haven't, then I indicate that I would like to pair them with a therapist first, because they need to get a sense of what their trauma is, what issues might come up, as does the therapist that is going to be supporting them through the medicine journey if they are given the green light to go ahead. And then after that, then they are referred to one of our nurses, Harpreet or Catherine, for a free 30-minute info call, where the nurses will do a basic screening of any contraindications. Ketamine is pretty forgiving, and meaning that you don't have to, you can still be on antidepressants and take ketamine, whereas that isn't the case if you're doing MDMA. Active psychosis or recent psychosis is a contraindication. Uncontrolled hypertension, because ketamine does raise your heart rate. But our nurses will do an initial screening and then answer any questions they have and explain what our process is and what the pricing packages are. Then if it's a green light from there, then they are referred to our MD, medical director and medical doctor, for a 60 to 90 minute medical psychological assessment. And actually there's one step prior to that. We send them forms to fill out prior to that are assessing for anxiety, depression, and trauma. And as well, there is a pretty significant medical intake form that goes into trauma and experience with substances, so that we can start to get a sense of the person's sensitivity to different substances. There also is talk about other treatment modalities, so that the person is well informed about different things that they could try other than psychedelics. If needed, if it's someone that is presenting with a complex psychiatric or medical history, then sometimes we may also refer them to a psychiatrist that we have a relationship with that might do an oversight. I think it's called a diagnostic consultation if needed. And this is all about creating safety for the potential client, so that they know that we are looking at any possible negative indicators that could play out. We emphasize that this is not a miracle cure. There's many people that, are hoping, okay, I'm going to go take some magic mushrooms, or I'm going to come get some ketamine, and then I'm going to be all fixed. That isn't the case. The work needs to be done afterwards. The psychedelics facilitate the work that's being done. It's not a shortcut. And so then healing trauma is about restoring flexibility and giving the person an innate felt sense of safety. Once again, I know I know for myself, on my own experience, and what has been reported by many people, is that we might know something about our trauma history. We might know why we made an adaptation to become a people pleaser, or to be someone who needs to demand to have their needs met, or something like that. But these medicines can help us get a felt sense of the adjustment that we made, of the adaptation that we made, which can then allow us to recognize that it was something that happened in our past, which then allows it to be sorted into historical memory, as opposed to the trauma response of our brain interpreting it as it is something that could happen again at any moment. And that's what causes the trauma response of flight, freeze, or fawn. And so, and also, just so you know, the default mode record comes back online. These are temporary conditions that happen. And there also is something that's being identified as, there's sort of two trains of thought with this, that these molecules are allowing us access to what's called our inner healing intelligence. And our inner healing intelligence gives us insight about what we need more of, what we need less of. Something I didn't mention as part of preparation is intention setting. You work with the therapist to get a loose intention about what you would like to explore in the medicine session. We don't always get our intentions dealt with, but it happens way more times than not, in my experience. The other train of thought from a plant medicine, ayahuasca and psilocybin, indigenous practitioners, they have a belief that it is the medicine itself that is giving us the insight. Whichever it is, we get insight about what it is that we need more of, need to let go of, how we're keeping ourselves stuck, something old that we are responding to that we need to let go of. And so in the integration work, it is taking those insights and using journaling, drawing, music, breathing, connecting with nature, with a different focus in allowing us to create sustainable change from the insights that we're given. With, just very briefly, and with ketamine, typically clients are looking at 6 to 8 ketamine sessions spaced either weekly or bi-weekly. We can space it out a little more. Some people have just had one session and have found benefit from that, but typically 6 to 8 sessions are needed in order to fully reinforce the new neural pathways. And then sometimes maintenance sessions are needed, once a year, something like that. But it is also very individual. With psilocybin, Health Canada typically would only give enough medicine for 1 dose. Now they will sometimes give enough medicine for 2 doses. And with MDMA, it's 3 medicine sessions if needed, spaced 1 month apart, with integration sessions following all of the dosing sessions with all 3 of the medicines. I think that's pretty much it for my part of the presentation.
Thank you, Dawn. I just want to share some announcements, but before I do that, I do want to take some time to thank you for sharing your expertise and insight with us. We're really grateful for your knowledge and the thoughtful perspective you brought to this conversation, as well as sharing some of your own lived experiences as examples. I will keep this very concise, but we want to make sure that you're aware of what's coming next and how you can stay engaged with Port Credit Therapy Center. So something very exciting we've been working on behind the scenes is we are developing pathways for possible OHIP-covered ketamine-assisted therapy. So if you are interested in being notified about potential OHIP-covered services, you can join our waiting list. Visit our website, portcredittherapycenter.com. Click on book a consultation or info call, and that will direct you to a form where you can request what you're interested in. So whether that's ketamine-assisted therapy, psychedelic-assisted therapy, general therapy as well,
you will also see an option to check mark OHIP covered PAT waitlist. You can mention that in the blank space below labeled paragraph as well, or email us at info@portcredittherapycenter.com, and you can always request inclusion, which you'll also find in the next following slide. And for our therapists that joined us today, if you're curious about how ketamine-assisted therapy benefits your clients, or if you're wanting to better understand how a collaborative multidisciplinary model of care with ketamine-assisted therapy works, we will be hosting an upcoming webinar dedicated to our co-care program. So in that session, we'll walk you through how multidisciplinary collaboration works in practice, the therapist's role in preparation and integration, clear referral pathways and communication processes, the ethical and the regulatory scope of practice considerations as well. So in our co-care webinar, our goal is to provide some more clarity around how to work together safely, ethically, and still keep our clients at the center of the care. So details for that co-care webinar will be shared through our newsletter as well as our website. So we do encourage you to stay connected. You can always stay informed by following our Instagram at Port Credit Therapy as well. Lastly, something very exciting, we're also hosting webinars monthly, and our next webinar will be focusing on nervous system regulation tools to help better manage stressors. So it is a scary world out there, and we want to help you find the support you need to help navigate it. So next month, join me as I discuss meditation, breathwork, connecting with nature, music, immersive virtual reality apps, and somatic techniques. So we do hope you can join us next month as we continue to focus on expanding integrative, regulation-focused approach to mental health care. So as we do come to a close, I do want to thank everyone for being here. We will have about 10 minutes for Q&A. If anyone does have questions, do drop them in the Q&A section of our webinar. We hope this webinar was informative, and if you were able to take anything away that was meaningful or applicable to your work or personal journey, do let us know in the chat. We would love to know what you've learned, something new, something exciting, what sparked your curiosity, and what next steps you're looking forward to taking after this webinar. And again, thanks everyone for being here. If you have time to stay and ask questions, we would love to engage with you in that way. And that said, Alex, I will hand it off to you, and then we can follow with some Q&A.
Amazing. Thank you so much. Of course, if you have any questions, feel free to leave them in the Q&A section. There's a bit of a prompt there, so you can add your questions in there. We do have one from Dan. So can you share what a typical timeline would be from deciding to want to do ketamine-assisted therapy for the first session after all the consultations?
From deciding to want to do CAT to the first session. At the moment, it's pretty quick because we aren't all that filled up yet. So we would be looking at, depending on availability, it is conceivable that providing somebody has had therapy before and has some awareness about their trauma and what they're wanting to work through, then here is close that is coming up. And there is support available. They have a consultation with the therapist that is a free consultation with the therapist that is going to support them through the medicine session. The info call, the medical psych assessment, it is conceivable that all of this could happen within 2 weeks for the first medicine session if everything aligns and timing. I'll just answer that for SAP, for the special access permit, it's more likely to be 2.5 months. It takes about 2 months to go through the approval process with Health Canada. I think I saw, okay. What form, Greg? Yes, what form is the ketamine administered in? 3 different routes of administration. For low dose, we use a lozenge, or to start. And what happens with a lozenge is you put it in your mouth and you swish it around your mouth for 18 minutes without swallowing your saliva, giving the mucous membranes in your cheeks a chance to absorb the ketamine. And then if needed, if someone needs a booster, we check in about 10 minutes after 10 to 20 minutes after to see if a booster is needed. And if so, then the booster is delivered via nasal atomizer. If we are doing a high dose ketamine journey, then we start with the lozenge again as well. And then we use an intramuscular booster for the top up if needed. And there's with different routes of administration, there's different what's called bioavailability. And so it happens quicker. And like when we do an IM booster or we do the nasal booster, the client feels the effect of the added medicine much quicker than the initial dose. I also didn't talk about cost, so let me just throw that in here. Unfortunately, OHIP in and of itself doesn't cover this unless we have an MD that an MD psychotherapist that is also going to be supporting the patient through all pieces of it, the therapy portions as well. As Harpreet had mentioned, we are in discussions with possibly getting an MD psychotherapist that will only be available on a part-time basis. But what happens, what can happen is if you have insurance benefits that cover therapy, then the way we break it out is that you can claim the preparation therapy sessions. For the low dose psycholytic, you can claim the 2-hour talk therapy under your benefits, as well as the integration therapy sessions afterwards. With a high dose, then it is, again, the preparation and the integration, and then an hour. We do sort of 30 minutes of supporting the client before they have the medicine with breath work and answering any questions, and then 30 minutes. Often when people come out of a high dose experience, there is a desire to start talking about what their experience was, which is already talking about already starting integration. And so we carve out 30 minutes there. And so that hour can be claimed under insurance as well as the integration sessions. Psilocybin, same thing. It would just be the preparation and integration. With MDMA, because there's talking that is going on, relational talking that is going on through that, then it would be possible to bill more to insurance if you have a good benefits package.
Dawn, there are 2 follow-up questions to Dan's initial question previously, so I think they work well together, so I'll mention both. 1, are there any potential permanent negative side effects? And 2, how do you decide the dose, low or high? And who makes the decision of dosing?
Okay. Okay, let me just... potential with there is a risk with ketamine if someone has a substance use disorder in the past. What we are doing is someone is coming to work with it. Also is helpful to support people that have substance use disorder, but there is a possibility that it could activate an addictive pattern. So with ketamine. So what we are doing, my medical director is requiring people to have 6 months of sobriety before undertaking a medicine session. And we will pair somebody with one of our therapists that is experienced in addiction counseling to help them maintain that 6 months of sobriety. But we're also, we're checking for this as well. Where before each medicine session, we're finding out how the person has been. If, we'll look for flags if someone wants to keep increasing the dose to an extent that seems a little out of the ordinary. So that can be, that's something that we have to look for. There has been some anecdotal reporting of the importance of screening for narcissistic personality disorder, in that there have been, just anecdotally and very few reports, but there have been some reports that there can be increased suicidality with people that have narcissistic personality disorder because they can come out of the medicine journey with an awareness of how much hurt they have caused other people. And if they don't have enough supports in place, that may be something that is too difficult for them to process. But again, this is part of what we're doing here, where if a client does not have their own therapist, we are pairing them with the therapist so that there is somebody there beforehand and afterwards for therapeutic support to help minimize that. There is a potential. I'm not the medical person here, so I'm a little, soft on how definitive these things are. But I believe that with bipolar disorder, there is a chance of someone going into mania. That is manageable once we know about it, and I think that can be triggered from ketamine if there's undiagnosed bipolar. But it also can be very helpful for bipolar as well. Harpreet, do you have anything else, or Catherine, if you're still there, anything else that you can comment on that?
Yes, I can definitely add to that, Dawn. So one thing I would like to add is during the medical evaluation with the Dr. LeMay currently, is that we do carefully assess any potential risks related to your personal history. And there is a very thoughtful and measured approach when prescribing. And so safety is always prioritized as well as your well-being. And because it's a controlled therapeutic environment, it does help reduce the risk of misuse and keep the focus on the healing. So when it's a structured clinical setting with a limited dosing and therapeutic intent, the risk is low and it's very carefully managed by our care team. And that's also where the integration support piece comes in. We're helping you process your experiences, stay grounded. You're working through the insights and some of the challenges that might be activated, and we're providing you ongoing care and guidance.
Yes, wonderful. Okay, how do you decide the dose, low or high, and who makes the decision? Great question. This is part of what we're assessing for in the medical psychological assessment. We'll ask about, are you a one glass of wine and you're a giddy kind of person, or do you have to drink a bottle? Have you had any experience with psychedelics? So that we can get a sense of that. What we suggest is that people start with a low dose of ketamine. And I think that also helps create safety as well, so that we aren't parachuting ourself into a high dose experience. And sometimes we can have a very strong hypervigilant part of ourselves that can go hold on weight that's far too much too quickly and can override the effect of the medicine. So by starting with a low dose, that also gives us a sense of how the person tolerates that particular medicine or molecule. There is a discussion as well between the doctor and the client. This is what I'm thinking. How do you feel about that? And this is part of the trauma-informed approach, where we are including the client in the whole process. And if the client, and if Dr. LeMay says, I think that we could start you on 100 milligram lozenge, How do you feel about that? And the client says, oh my gosh, that's way too much. Then absolutely, we take that into consideration and we would lower the dose. And this is also nurturing trust in self and that inner healing intelligence, that we know what feels right and what doesn't. So that's factored in. And when we are looking at, potentially 6 to 8 sessions, then we're using each session to inform what the dosing will be in the next session. So I hope that answers your question. And are there any other questions that anybody has? I don't know what I just did. Oh, there we go. Okay. I think that's it. Does anyone else see that if there's any other questions that I've missed? No. Okay. So thank you all for joining. If you go to our website, there is pricing on the website. We do have bundle packages as well, that I don't think those are laid out. If this also from continuity of care, that if you talk to your doctor and you get a referral from your doctor, then that can facilitate the process on our end, and our MD potentially billing OHIP for the med psych assessment. And then what we would do is we would provide a note to your doctor afterwards, but this isn't also a prerequisite, because not all medical practitioners are supportive of psychedelic therapy. And so we don't want to put your relationship with your medical practitioner in danger. And hopefully at some point we will be able to at least offer people who meet the criteria some OHIP covered psychedelic assisted therapy, as well as the fee for service, which will be a little quicker, I imagine, once we get started with that. But it helps, when you look at if you can bill some from on benefits, then that helps reduce the cost. And when you also look at the possibility that this can eliminate the need for weekly or bi-weekly therapy sessions, and giving you a deeper sense of healing and ability to navigate the world, then I think that that's really important to factor in. So thank you. As has been said, if you go to our website and click on the book a consultation, you can get on a wait list for that, or even get more information. And I'm happy to schedule a 15-minute intake call to give more information. And for any therapists that are out there, the co-care system program that we have, there's 3 different tiers where therapists can be involved, which helps to create that trust container for their own clients. And we'll be doing a webinar on that probably in a couple of months. So thank you very much. I wish you all a wonderful evening, and take care. Nice. Oh, I missed that. OHIP covers 6 sessions a year for pain management. Yeah, that's for pain. Yeah. Pauline, okay. Wonderful. Thank you. Thank you. Thank you. Okay, how do you think it went?
Made great timing, and I feel like we got everything we needed to say in. Cool. And I guess too, Harpreet, is there like do they automatically get a recording, or do you have to like export that and send that out?
I believe I have to export it. There's 2 options here. One is end event. I don't know if that ends recording or if it exits me. That's where I'm a little hesitant. Okay, I'm just gonna click it just to see. One moment.
Sure.
I'm holding my breath. Okay.
We're still here.